Okay, well, we're going to go ahead and get started. Welcome to the IDRPP's Autism Echo. We're thrilled to have you. Again, if you'll just put your name and contact information into the chat, just helps us continue to build that community networking and know who is on the call with us. As you notice, we are recording today's session. We use that for quality and educational improvement processes. You are also free to utilize these recordings and go back and check them out and share them with colleagues. But by participating in today's session, you're consenting to be recorded. So please don't hit that leave button, but if you have a big, strong issue with it, about being recorded, you can go ahead and leave today's session. I just always want to give a huge shout out to Colin Kingsbury and the Children with Special Healthcare Needs at Department of Health and Human Services for providing funding for this project. With their support, we are really making some huge differences in the lives of children and families. And hopefully you guys all enjoy these sessions. If you've never joined an ECHO session, thank you for joining your first one. We will always have a subject matter expert. Today, we're thrilled to have Michelle come and present to us about health disparities. We will have a case presentation. We have a participant, Stephanie Slogla, who is going to be presenting the case for us, and then learning from all of you amazing people on the call about recommendations for her case. Again, that just builds that professional networking. I know sometimes it can feel like we are all out here doing this work alone and not knowing who to reach out to. And so by just continuing to connect with each other on this call, we can reach out to each other and say, oh my gosh, that idea that Gretchen just put her name in the chat and it came across. Gretchen shared this great thing. I know she works at the Utah Parent Center, and now I can reach out to her to ask further questions about some of the work I'm doing. So we love that interaction. If you have a question or a comment as we're talking or want to share, please put that into chat. Colin, our hub member, does monitor that for us, and we'll make sure that those are getting asked and answered, as well as just a plug for a case narrative. Again, like I've said, it sometimes feels like we work with some pretty challenging families or situations, and we're just not sure how to proceed, or we want to make sure we're on the right track. So a case narrative is really a great way to do that. If you would like or interested in doing that, please reach out to Autism Echo at aggies.usu.edu and we'll get you on the schedule for that. As we're talking about just that interaction, please just use some session etiquette. So respect our presenter by using the chat or raising hand to ask those questions. Keep your questions on topic and brief. If you can, turn on your camera, and then also be sure to introduce yourself. Again, it's just that way to continue to learn and know who we all are on this call. And protect individual privacy. So de-identifying information, if you have any questions about that, please put an asterisk. All the hub members have an asterisk in front of their name so that they are easier to find in chat. Renaming your profile and raising your hand feature. We've all been on Zoom forever now, but another step of how you can do that. Again, if you have any questions, Leo is great to help you work and troubleshoot any Zoom issues. Throughout today's session, we will be dropping in a survey. In order to get a credit of attendance, we do ask that you complete that survey, and then certificates are mailed out monthly. thank you to everyone who fills out those surveys. It is a great way that we can show and share the great information and things that are happening in our ECHO networks. We store everything on our Canvas platform, so recordings, handouts, PowerPoints, all the case recommendations that are gathered throughout the breakout groups are stored and able for participants to go back and utilize. If you would like access to our Canvas page, again, just send us an email at autismecho@aggies.usu.edu, and we will get you set up on our Canvas page. Just another plug for those case studies. It really is a great way to get valuable feedback. There are so many amazing people on this call that has great resources and information to share and show with everybody. We do have social media. If you've not followed us on social media, take a minute to do that. We share information about sessions, resources that are shared with us, information about anything that we get as an ECHO group. I'm going to stop sharing and turn the time over to Michelle, our amazing presenter today.
Hi, everyone. It's good to be here. Let me just get these pulled up. All right. Can everyone see that?
Yes, great.
Perfect. So I'm here today to talk with you a little bit about autism and kind of from a disparities lens. So I have a lot of data and kind of fun facts around this topic to share with you. Some real life Utah data too. So hopefully to kind of ground us in what's going on in our communities here. The one thing that I'll say is just please jump in with questions. I have some people working at my house. So if there's noise, please, I apologize. But just let me know if you have questions, put them in the chat, and Colin will highlight them for us, or raise your hand and I'll try to pay attention to some of that as well. I'm happy for this to be interactive. I'd love to hear real life examples too as we go. For those of you who don't know me, I see a lot of familiar names on here, but for those of you who don't know me, I'm a professor of pediatrics at the University of Utah and the clinical director of the developmental assessment clinics, which I think most of us know or have heard of also as the child development program. We see children who have any risk of developmental delay, concern for developmental disabilities. Through our program, we do a lot of autism assessment. About 60% of our families are looking for questions around autism diagnosis. We also have a neonatal follow-up program where we follow our NICU babies over time, and a heart follow-up program for our infants who have undergone extensive heart surgery early in life. But we really monitor development across all high-risk groups. As everyone here knows, that really impacts development, and we see potential for delays across a lot of medical conditions. So we see a wide variety of kids. I'll share one update for our program just so everyone has that information, and that is that we are currently moving locations from Primary Children's in Salt Lake over to the Riverton Primary Children's Outpatient Clinic starting this summer. We hope to have a more firm date on that probably around June, but we will be in a new location and more to come on that we'll be sharing out with the community. All right, so back to disparities. This is my cousin Ezra after he graduated high school, and Ezra has autism and an intellectual disability. So I like to share my story about Ezra because I think it highlights a lot of the numbers that we're going to see today. Ezra's family, my family, is largely from Mexico and has a bit of a different approach to healthcare and experience with medical providers than maybe a lot of our families do. And as a result, Ezra didn't get diagnosed with autism until he engaged with the school system. So once he hit kindergarten, he was still nonverbal and struggling with a lot of different behavioral challenges. And it was at that point that the system was able to provide him a classification of autism in the school, and then he moved forward with a medical diagnosis and so on. But because of that, I know that he missed a huge window of early development that I know all of you here know very well about, those first few years of life, really being able to intervene. And I think we've shown over time, because we've shifted the numbers to look like more children with autism are verbal and are what we would call kind of in that more of that higher functioning category now. When I first started in this field over 20 years ago, the numbers were the other way around. Most children with an autism diagnosis had a comorbid intellectual disability. And I think in large due to efforts around early intervention across the country, we have changed and shifted that narrative, which is amazing. But we still have children who do take that nonverbal path for a lot of different reasons. And we'll never know if Ezra was able to, become verbal at some point because we didn't have that opportunity for him to access that early intervention. But we know that some children, because of genetic differences, they don't go on to develop language, right? Regardless of intervention. There's different phenotypes of autism that we'll talk about. But I like to think about ways that we can intervene to make sure that all children equally have the right opportunities to access the interventions that they need to. So we have our prevalence person on here. But what we know about autism and prevalence of autism right now is that about 1 in 31 children have a diagnosis of autism. We know that it's about 4 times more common among boys than girls. And about 31%, maybe less now, have an intellectual disability as well. Most children are diagnosed after age 4, but we know that there's a lot of disparities within the age of diagnosis, meaning that some children, say, for example, we used to observe a trend where Black children were diagnosed later than white children. That trend has started to even out, and those numbers are the same. However, for Hispanic children, that number, that age of diagnosis is still remaining later. So we're closing some gaps, but still see a few. So I like to share this slide. Has anyone seen this before? We talk a lot about the word equity, I think, gets thrown around a lot when we're talking about trying to do things the same way for everybody. So I like to kind of think about some of the subtleties in language here because I think they are important. When we're thinking about equality, equality is just a basic assumption that if we all have the same size step stool, then we can all see over the fence. Like everyone should be given the same size step stool. And we know that's not true because we're all different people, right? The world is a very diverse place. Some of us need bigger step stools to be able to see over that fence, right? And that's equity. Equity is making sure that everyone can see over the fence, not that everyone has the same supports. So providing the same supports doesn't always work because some of us need different supports. And that's where equity comes in. We need different supports to be able to do the same thing. Justice is taking down the fence so everyone can see, right? Really kind of identifying the root cause of the problem. That's always our ultimate goal is, well, why do we need the fence there in the first place, right? Let's just get rid of the fence and then everyone can see. We don't need step stools of different heights, right? So that's kind of just a language piece that I like to highlight and for us to think about as we talk about some of these issues. This is a slide that I really like because it kind of highlights the differences in access to services across a pathway. You know, we all work within this very challenging healthcare system that is really not designed for children with developmental disabilities and autism, right? We make it work most of the time. But this slide highlights the exact places where a child could fall through the cracks. And within these 9 boxes here, you can see many different places where they might slip through the system. So you start at the very beginning where we have caregiver or provider concerns about development. A parent says, I don't know, I'm feeling like something's not quite right with my child's development, or I feel like they're behind in speech. Well, this could look different if we look at the text in red here. An example of where where there might be some differences or where children might start to fall through the cracks is that these presentations can look different. Communication style among parents to providers can also look different and be challenging. We have a lot of documentation that shows that parents of African American children or Hispanic children, they're often dismissed the first time that they have a concern presented to a provider. I see this quite often in my own practice as I see a lot of Spanish speaking families. And it's often the case that parents will say, I said I had a concern, when my child was 18 months old, but we did the wait and see thing. Or maybe there was a communication gap just in the fact that there's 2 different languages being spoken, right? So things kind of can get missed early on. And we know that it takes about 2 years from the time that a parent has a concern to the time that they actually can get an evaluation on average in the US. We think that is too long. We think that should be 3 months. That would be the ideal time frame. But it's been pretty well documented that because wait times are long and there's high demand for evaluations, that families are waiting about 2 years. So the next place that these kids could fall through the cracks, any kids could fall through the cracks, is just by surveillance, kind of dismissing that, caregiver report. And then the tools that we use. A lot of the tools that we use now, they are in multiple languages, which is great. They're not necessarily normed in different languages, but they're written in different languages. And we know that autism can look different socially across cultures. Thus far, we have not integrated culture into our autism assessments yet. So this is why it's so important to have matched ethnicity providers doing autism assessments as much as we can. And that's true for all medical care and has become a recommendation of the AAP over time. It's very difficult to make happen, but it's important. One example I can think of is I was doing an evaluation in Spanish with a 9-year-old boy, but he was from Colombia. I know Spanish in the way that I learned Spanish, which is Mexican Spanish. And there were times where it was really unclear to me based on the way he was speaking, if it was a stim or if it was just a different intonation used in that version of Spanish. And you'd think that even just for Spanish, you'd be able to go across cultures. But when I had someone in there who actually spoke that version of Spanish, they were able to clarify for me some of those things. So there's some tests that really just don't help us kind of pick up on some of these subtle differences because autism is a social communication disorder. And then identifying services, trying to find the correct services for families, especially for our families maybe in rural areas who have limited access to resources, and getting them plugged in with the right resources. The paperwork process, we all know that takes a lot to apply for medical assistance, Medicaid waivers, et cetera. And then the referral and diagnostic testing pieces. We know that for Black and Hispanic children, there are higher rates of missed and misdiagnosis, which I'll talk about a little bit later. And then all the way to ongoing service navigation and trying to understand the right path for a family to take in terms of navigating their services and helping them navigate those services from early intervention all the way to the school system. A lot of these don't have kind of the right kind of nuanced supports always built into them. So there are families that can fall through the cracks here. So we're trying to find places where we can improve. And we know that here, if we look at this kind of timeline of autism diagnosis and age here, you can see that, you might have a parent with a first concern around 2. And it's not until 2 years later that we see that child accessing that diagnosis. So where can we intervene? Well, we can make sure that that developmental surveillance is happening, right? We can also make sure that it's happening across all cultures and all of our populations. And then, let me see, I've got stuff covering up my screen. Here we go. We can also try to close that gap by getting the kids screened earlier and into the system sooner. All right. So I've used the word screening and evaluation, but we also have this kind of concept of surveillance. Surveillance is really what happens, what we think is happening now pretty well in our primary care offices, where we've got our pediatricians and family practice providers, our early intervention providers, all kind of capable of recognizing children who might be at risk. And this happens at those well child visits pretty routinely. But then we also have things like the MChat and the POSI, which many of you I'm sure have seen or heard of, that get used in screening. And this is a standardized tool that can actually help us identify those children who might be at risk. But then the evaluation piece is really that actual diagnostic component. So there's really three processes that children go through here for getting a diagnosis. We know that screening has been one of the most beneficial and effective ways to increase or to equalize the rates of autism across all of our racial and ethnic communities. If we're screening universally, then less children are likely to fall through the cracks. And we know this is also getting children diagnosed earlier. We use the POSI primarily in Utah for screening, although we'll also see the MChat. So some gaps in care that we are able to note are both quantitative in terms of numbers, but also qualitative in terms of like what we see as providers and providers that work with families with disabilities. I think everyone has a story about a family that you meet and you hear that like they've been trying for so long to get the right services and they just haven't had the right resources to figure it out. We know that I think some of these numbers are a little bit old now and need to be updated, but about 2.1% of Utah children have autism compared with 2.9 nationally. But in rural Utah, the numbers are even lower. And these are from a couple years ago. So we know that the prevalence of autism in rural Utah, rural counties, is much, much lower. And we don't think that's because autism doesn't exist in those counties. It's just that those families are not accessing those diagnoses and those evaluations as well as they are in urban areas in our state. I think those numbers are improving slowly over time, but they are still lower. And then we also know that Black and Hispanic children tend to get diagnosed later. The gap seems to have closed a bit more for Black children, while Hispanic children do tend to be diagnosed later. These groups also tend to be diagnosed with a comorbid intellectual disability, which is likely related to that later diagnosis, right? So if we're not getting our kids into interventions until they're older, the likelihood of them developing language is a lot lower, right? After, age 6 or so. In our clinic, we know that our average age of referral is around 5 years old. I think this has bumped down to 4 in the last couple of years. But the age of diagnosis for Hispanic children is a bit older. And we also see this for our rural children. About 13% of children with autism living in rural Utah are Hispanic compared to about 17% statewide. This is the old data here where you can see the kind of differences in prevalence and diagnosis among Black and Hispanic and white children. So we know, like we said here, this gap between white and Black children is changing. and it has closed, but we still see a pretty big gap between white and Hispanic children in terms of prevalence and our intellectual disability diagnosis. More children are getting evaluated by 3 years old, and in Utah, we have reduced that number pretty well just in the last couple years. Some of our groups that track that just recently published some data showing that our early screening seems to be working. We know that some of these barriers can include families who don't speak English, just a lack of access. And then we also know that stigma plays a large role in this, especially in some of our rural and Native American communities that we work with. Here we can see our child development program referral data from what we call our medically underserved areas. So our medically underserved areas, these are HRSA designated areas. And what I wanted to look at here was just the average age of referral. So how old are children when they get referred for an autism evaluation in these medically underserved areas? And for those, for example, you can see San Juan over here. Those kids are getting referred to us at an average age of about 8 years old, compared to some of our other areas that's closer to 5. So it's about a 3-year difference, which is fairly significant. So we've been working really hard with those family practice clinics down there, and in a lot of these areas, I think I saw Gwen on here, to get that age of referral down. So kids are being sent to us earlier than 8 years old. So here's kind of just a big pathway where you can see, if we start on the left here, where you're thinking about, do you have any concerns about your child's development or the child you're working with in their development at these visits? Was autism screening completed? If it was negative, then you can go here, and then you go back to each visit, right, and repeat this. If it's a positive screen, there's a lot of different pathways that we could take. What we know is that even when children screen positive on an autism screener at one of their well child visits, 1 in 4 providers don't refer for an evaluation after that positive referral. We don't exactly know why. I think that's something that we're trying to understand a little bit better. But we know that that's a missed opportunity, is that lack of referral that happens for about 1 in 4 kids. So I talked a bit about a miss or missed diagnosis. Let me tell you what I mean about that. So a diagnosis often occurs well after that 42 months after parents have a concern for Black children, meaning that would be a missed diagnosis. An opportunity was present, and that diagnosis didn't happen when we know it could have. And usually when we interview parents about that process, they say, no, I knew something was wrong. Parents always seem to know, right? I think that's one thing I've learned in my time doing this. But then there's also increased financial and material burdens that happen as a result of some of these missed or misdiagnoses, right? So for a child who gets a late diagnosis, maybe ends up with a comorbid intellectual disability, the cost of caring for that child goes up significantly. And we see this documented in the like Medicaid data showing the cost of caring for a child over a lifetime with autism or with a developmental disability. We know that our own biases impact timely diagnosis and how we perceive an autism diagnosis to look in a child that's Black or Hispanic or of a different ethnicity. And for parents of Black children, they're more likely to have concerns about communication during an autism diagnosis. And I can say just from my own experience, this is true for many families. Speech is almost always the first concern, right? My child's not talking. Around 2, we hear a lot of parents start to have concerns. And when you ask them, looking back, what were your concerns? They'll often say that it was speech. There was challenges around communication. When we move into thinking about treatment, we know that treatment is needs to be culturally tailored. But this is very challenging for us to do, right? Because we don't know a lot about what it looks like to tailor an autism treatment in a culturally appropriate way. There are more and more data coming out on how to do this and more research, and I think better treatment options for different communities. But we know that it's not a one size fits all. We know that developmental milestones are developmental milestones across cultures, but they can look very different, and engaging with these families in a way that's meaningful for them is critical in order to move treatment forward, right? So as we're thinking about sort of those next steps after a diagnosis and getting families into the right treatment, really thinking about whether or not we have the right treatments for these families is important. Because I think it really comes into play with engagement and keeping these kids in treatment over time. These are a couple resources that I like for children with profound autism, for Hispanic families, and then The Color of Autism is a great resource. There's free parent groups, all kinds of resources through their program. And then Autism Speaks does have some great non-English resources as well that I like to share. And then I put this link in there for anyone who wants to kind of watch this video when they have time, just kind of highlighting some different stories of children and families going through the diagnostic process. Oops, here we skipped one. And then these are just some nice like resources around like trying to understand our own biases and our own practices in equity screening for autism specifically. So I put those in there as well for you all. This is sort of the process of trying to understand gaps in care, examining our role within those gaps, seeing what we need to do to change those, try to figure out how we can track if we're going to change those, prioritizing things like bilingualism and biliteracy, which ultimately sort of just diversifies all of the information that we know about autism and hopefully reshapes how we think about autism and what it looks like across cultures. So I just like to share that little circle, and that's it. I haven't looked to see if there's questions, but I'm happy to take any.
So, Michelle, this is Janelle, and I have a question for you. So, as early child providers in early intervention specifically, what are some of the things that we can do to help encourage or do that better?
Yeah, I think let me pull that slide back up here. Let's see. All right. Are you seeing my slides? I can't tell which.
Uh-huh.
Okay. Yeah, I think when we look at kind of the pathway and access to services, or we look at this timeline as well, I think it's really kind of starting in these first couple of years when parents start to say they have concerns. Um, really, really listening to them and trying to validate those concerns and understand where they're coming from. Even if maybe we as providers don't see any concerns for autism at that time, that's where we've seen the biggest impact happen over time. And I'd say that's probably where, early childhood providers can continue to do that. It's been shown that it's working.
And then there is a question from Gloria that she's asking, can you go back to the reading resources?
It's like these ones. These ones?
Gloria, I don't know. Are these the ones you
Yes, but can you open it up because it's um I can't I can't see the full screen.
Let me see.
And Michelle will share these slides with me after the session and we'll email those out as
Okay.
well to everybody, and they will be stored on our Canvas page.
Okay.
Is that better?
You do now have a thing that says continue to share, like you
Oh,
just needed to click a button.
let's try again. How about that?
Yep.
Okay,
Hi, Michelle. This is Leo. I have a question for you.
sure.
So, I guess okay, so I'm Latino. I come from a Latino background, and I was just wondering, how do you kind of address those cultural differences in, I guess, the way Latino people or a Mexican person were to think of autism? Because I know culturally, at least in Mexico, I don't know if there's an actual system to really provide services for people with intellectual disabilities and or intellectual developmental disabilities. So I was just wondering, how does that cultural difference kind of pop up in your work, and how do you guys address that in your clinic?
Yeah, those are great questions. And you're right. In Mexico in particular, there's not a system like we kind of have here in the US. So it does occur mostly in the school system, um, which also happens here in the US. But as we know, you need a school classification and a medical diagnosis in order to access the appropriate services. Um, so in terms of kind of working with Hispanic families or Spanish speaking families, are you kind of wondering like what's been helpful, or at what part in the process are you sort of thinking?
I think honestly, maybe even all parts, like what's been helpful, or maybe you could say that, let's say a parent kind of just doesn't really agree that their child may have autism. How would you go about that and maybe explaining to them kind of the benefits of accessing services early?
Yeah, I think that can be really hard across cultures. There's this concept of readiness for diagnosis that I think is really critical. We did this screening study where we just screened a ton of kids in primary care and tried to get them, diagnosed really early when we just really implemented 100% universal screening. And a lot of these families were just, they didn't have it on their radar. It wasn't something they were concerned about yet. Their level of readiness for that diagnosis was pretty low. In my experience, we really follow the family's lead on that. It's really challenging as providers to say, this is what I recommend. It never changes my recommendations or my opinion about the diagnosis. I always give the diagnosis, I always give the recommendations. I always implement the follow up. In fact, I probably would say from a strategy perspective, I follow those families more closely and really try to work on rapport over time with them as well. And when they're ready, they engage in service access. Um, but it's may not be at the timing that we want it to be, and that's really hard as providers.
Thank you.
So if other people have questions, you can put them in the chat or come off mute. And so, Michelle, while we're waiting for that, I do have a question that you mentioned some things about that universal screeners, and how they are in the, they're interpreted into or translated into other languages.
Mhm.
But they're not always, like you mentioned, looking at those cultural norms. So, how do you kind of, as a provider, interpret that, um, and not wanting to either like ding them because they're not doing a thing, but that's like one that I can always think of is on the ASQ and it's using utensils. And there's a lot of cultures that don't use utensils. And so they're not doing that, but that's not part of their cultural. Does that make
Yeah.
sense?
Yeah, it makes a lot of sense. We have standardized tests that we don't score, that we just use clinically, to say, we did this, but we recognize that this is not a valid question for this particular family for whatever reason, whether it's cultural or, I think even things like girls is a great example of disparities. A lot of our assessments are not designed around the female presentation of autism either. And we're learning that we need to have better tools to identify autism in females. So sometimes what you'll even see in our reports is that I'll do something like an ADOS, but I won't score it. And I'll say that I didn't score it because it wasn't valid, either because there was an interpreter being used, or it wasn't an appropriate tool for that particular child. And that's challenging because sometimes you need a standard score for something, right? And saying as a clinician, this is my best judgment, and I want you just to rely on that. We just have to hope that when it goes up to the powers that be at Medicaid or wherever else that it goes through, it usually seems to. And thanks to a lot of our collaborators at Medicaid, we have been able to build in that flexibility over the years. But it is hard.
Great, thanks. And then it looks like Kathleen and then Gretchen. So
Okay,
Kathleen,
sorry, I couldn't find my raised hand.
you're good.
My question is closing that gap. Is there any way we could get, okay, for example, pediatricians may do an MChat, but they rarely give it to parents, or parents don't understand what it is. But they give them our phone number and tell them to call us, which they do. Then we do the evaluation. We may or may not know they've had an MChat done. But then that takes it even longer once we do the evaluation, then to have the provider come in. And, we're talking months down the road, where a provider may understand, recognizes the signs. But this could have all been prevented if at the very beginning, the pediatrician let us know that they had done an MChat. This is what the findings were. And we could, start it right at the very beginning instead of months down the road. Is there any way we can connect better with pediatricians around the state of Utah to get the information at the very beginning?
Yeah, that's a great
Does
question.
that make sense? Okay.
Yeah, it sounds like kind of that communication gap from the, primary care providers to our early interventionists is still there. Not always being closed. Yeah, it's two different systems. I think I put on my my system level hat. I'm like, well, these are two different systems of care, right? So they don't talk to each other. Like there's no infrastructure for them to talk to each other. Whereas if the pediatrician in, this clinic here within, Intermountain sends me a message, right, that they have a concern about this child, we can easily talk to each other because we're in the same system. But for you guys, it's two separate systems. And it's when I see that there is no natural link, then we have to build something, and something that's sustainable that people will actually use, right? That's the root cause of the problem. But I agree. It's a hard situation. It puts a lot on the treating providers to try to close those gaps.
It just seems like it would be a place to start. I don't know. Yeah. I mean, we get emails quite frequently if there's a lot of concerns, but if it's just an MChat, typically we don't see those, and typically we don't even hear from the parents that it was even given until much later down the road, because they don't even really understand what the meaning of it is.
Yeah. Yeah. Often the screening results are not explained well, if they're explained at all.
What I love based on what you guys are also talking about, and I was trying to quickly find it, is that by utilizing the posse that a lot of Utah providers are now going to, and doing that within their electronic medical records, it's actually increasing that. And I love that that one is easy to use and it takes great, just that parent perspective. I don't know if you have that article that you referenced quickly, Michelle. I know I have it somewhere, and if you can't find it, I'll share it with everybody because that was a great.
Yeah, that would be great.
Okay. And then David has in there is he says, I'm building a ranch for vocational or for a vocational dude ranch for autistic young adults. I do not know how to access resources for building the curriculum and collaboration with agencies. Would your office be able to provide resources for getting something like that started? This would be an amazing resource for families.
Hmm. That sounds really, really great. I don't know that we could help with that in terms of curriculum. I would think like treatment programs might be more no problem. Might be more appropriate for some of the curriculum building. You know, I'm thinking like the School of Education or other autism therapy programs could help with curriculum type things. We do primarily assessment right now with our program. But good luck with that. That's exciting. That sounds great.
Michelle, I kind of have a question. I've been thinking about how to phrase it.
Yeah.
You probably answered like bits and pieces of it, but I have a little cousin who just very recently was diagnosed with autism. But the process kind of getting him here into that diagnosis was a little bit more of probably no more tricky than others, but it felt tricky for our family. He definitely at first struggled like with his talking. He like started to talk a little bit and it like kind of digressed a bit. So he was in like speech therapy type preschool. Then they started having troubles getting him to eat like any food. He was very, very limited on what he would accept texture wise and stuff. So they put him in like therapy for that. And so you had all these little things happening, but at no point like was anyone like really like, oh, like yeah, this could be autism. And then like by the time we got to the point where people were like, like maybe this could be autism, like his mom and his family was like, oh, like there's no way my son has autism. Like there's no way, like that just doesn't happen in our family. So I feel like it was like this complicated, like, oh, like what could this be, as well as like can it actually be? Like, can I accept that? And so my question kind of surrounds like, how do you help families really come to terms with that might be their reality when they
Yeah.
don't want to believe that?
Yeah, that readiness for diagnosis is and can be really hard, especially with multiple family member influences. I'll often do feedbacks with like one parent first, and then they'll say, like, can we do this again, but with my husband or with my parents, because they don't understand what autism is and aren't really kind of buying into it. I have found that you find that one member of the family that can be that champion for that child, and is able to move the needle in terms of resources. It sounds like they're getting lots of great therapies, which, you know, for autism, we do have ABA therapy, which is very specific to autism, but also a lot of it is a behavior difference, right? So we're often just treating behavior, and having speech and OT and feeding and all of that are great interventions as well. And often doing autism plus speech plus OT plus all the things is too much for one child anyways. Like They just need to go play in the dirt for a little bit, right? Like we don't want them in therapy all day. So it is a bit of a balance, but I do think finding that one family member that can champion things forward and then going from there. And I think always finding a good provider that is willing to explain that autism diagnosis to multiple family members when those family members are ready can really help. And sometimes it doesn't. And sometimes, I have family members that never really bought into it. And, Ezra's is different, and that's okay. His mom's his biggest advocate and, move the needle for him, while other family members, just couldn't do it.
No, thank you, Michelle. That's actually, I didn't even think about how helpful it might be to have the provider explain to other family members who might be causing like other like questions or hesitations with the diagnosis. That's honestly
Yeah.
quite brilliant. And just like for like a further update, my little cousin now is in ABA therapy and his
Oh,
other
great.
family kind of like dropped out just to allow him to focus and to get the help that he needs. So he's in a good spot, but I was just thinking about the process. So thank you for answering my question.
Yeah, of course.
Okay, I'll leave it open just one more minute for any other questions or thoughts that people have for Michelle. Always learned that on Zoom you have to give a ton more time than what you normally do. Okay, well, Michelle, thank you so much for your time and insights on everything. That was super helpful. I'm going to ask Stephanie if she'll talk so I can quickly find her on my screen.
I'm right here.
Well, that
Thank
didn't
you,
help
everyone,
me.
for having me.
Thank you. Oh, there you are, Steph. I'm like, that didn't help me when you talked. Okay, the Stephanie is going to be presenting our case today. So take it away, Steph. Do you want me to share your slides or do you want to share your slides?
Can you share 'em? Is that
Mm-hmm.
So while Janelle pulls that up, a little bit about myself. I got my degree in child development, and right now I'm working at the Up to 3 program in Cache Valley, specifically with kids with autism or early indicators or social emotional delays. So a little bit of background on this case. So Hannah is a 7-year-old girl. She lives with mom, dad, and 2 younger siblings. I'm currently helping with younger siblings in our program, so this is a sibling. She was diagnosed with autism a year ago. She was on an IEP for speech in kindergarten for a few months, but after that time, they felt that she was doing well enough that she's not on any IEP or 504 right now. So the biggest concern that mom talks about is that she'll have really big meltdowns, especially when she gets home. She has a hard time listening. She has a hard time following rules. She struggles with mealtime. Um, Mom says, especially like when she'll get mad, she'll like pretend to be an animal. So she'll like hiss like a cat. And mom's like, I don't know what you're doing, right? And then Hannah's teachers report that she does really well in school with grades. Mom isn't sure how she does the rest of school, but her teachers report that she's doing well in school. Some of the goals that mom would like to work on is less meltdowns and better behaviors at home. And then especially being able to communicate when she's upset instead of pretending to be an animal. Some of the barriers are, again, mom isn't sure what she's like at school. She doesn't qualify for an IEP at school, so there doesn't seem to be supports there. And then younger siblings also seem to be a trigger, like she'll be playing with something and they'll try to take it, or they're not playing the right way. Like one time they wanted to dance in the living room and she's was telling them you have to dance right here, but really the whole living room was open for dancing, so she would get upset with that. She's also interrupting their siblings' play with how they, how she feels it should be done. So if little brother's playing with something, she'll be like, "Oh no, you need to play with it this way," and then that kind of makes a little more chaos in the house. So mom has tried giving her space to be alone after school, which sometimes helps, but not enough to kind of settle the chaos after school. Mom tries to explain that certain toys are for all the kids or that baby sibling doesn't understand, but she'll still have those meltdowns and have a hard time, especially coming back after those meltdowns. So some questions are there any supports or information that mom can get from Hannah's school or teachers? Can she get supports at school that would help with behaviors at home? What are some other resources that are available outside of school? And how can mom help Hannah with her behaviors at home? Again, those meltdown, rigid thinking and play, pretending to be an animal instead of using words and not listening. Um, yeah.
Find my off mute button. Okay, so Tori has put us in breakout rooms and she's going to open those up. The hub members should have had their questions on what we're going to discuss with that, and we'll be hopefully popping stuff in between breakouts to ask further follow-up questions. So Tori, you can go ahead and well, welcome back. Hopefully everybody had some great discussions with it. We do have a little bit of time. Sometimes we don't always have this. So I'm going to let each breakout group give like an idea quickly. So Stacy, since you guys were the last ones back, it means you're the first one on my screen. So your group.
Leo, do you have the notes? I don't know if you want to read from that or if I can just.
Yeah.
Great.
I'll share an idea. I think what is really important is just to have the parents advocate for Hannah and the child, especially with the school, like seeing the situation and how it's going with the school system. I think just having the parents go to Utah Parent Center or another organization who may help them advocate for the child would be very beneficial. And we also stated maybe having Hannah access some of those like private resources, or I don't know if you could call them like just ABA therapies, perhaps, may be accessible towards Hannah because if the school may not be providing those services, I know you could still access ABA services even without an IEP. So I think those were some two really important points.
Great. Colin, how about your group?
Yeah, no, we had basically the same recommendations, advocating for more testing. We were kind of wondering if the child had a 504 or not. And then we had another suggestion, perhaps for some occupational therapy after school. Really kind of trying to find out if there is anything that's leading to the meltdowns. And then, of course, ABA. It can work for everybody. So ABA is a great thing. And then, yeah, I think that's kind of, also go back and maybe if the family has access to Dr. Gabrielson's two echoes, they might learn something from there that is helpful for them.
Great, good resources too. So, the one thing that stood out to me, so we were lucky and we had a parent perspective in our group. So Itara, she gave some great resources, but we also had a medical provider on there. And I think that's sometimes something we always forget to share, to reach back out to your medical provider. And if there are some pharmacological things that might help with that. But I also loved Itara's suggestion on the cat hissing, like meet her where she's at and have like create a dictionary. So Itara gave the example of like two hisses mean I had a really crappy day and a purr meant I was this. So I thought that was a really great approach too. Um, so Steph, we will collect all of those from everybody. So if everybody will send their notes to Autism Echo at aggies.usu, we will compile all of those recommendations and send those out to you. For everybody else, those will be stored on our Canvas page, so you can go back and access those for any other clients that may seem similar to Steph's case. Next month, we are hearing from Jason Fox and Dr. I'm going to say the last name wrong. Konkinski. They're from the South Main Clinic, and don't let them know that I just hashed their name completely. Just know that I don't say a lot of people's names correctly. I sometimes don't even spell my own name correctly. So, and just continuing to talk around the engagement of health disparities. So we're going to be really looking at that early childhood development for Hispanic and Latinx families. So hopefully you will all join us on April 22nd. Thank you all for your time and enjoy the rest of your afternoon.